Now that we've seen the action potentials that can occur in the autorhythmic cells, as well as the action potentials that can occur in the contractile cells, let's see how those two interrelate with each other. So here is a simple diagram in which I am showing the yellow circle as representing a collection of pacemaker cells. The cardiac myocytes then are basically interacting with the pacemaker cells. So the way that these two things are related is that the pacemaker cell is going to generate its action potential. Its action potential then is transmitted to the contractile cells. So it provides the voltage which will open up the voltage-gated sodium channels that drive the rapid phase of depolarization in the contractile cells. And recall that all these cells are interconnected by gap junctions, so the electrical change that occurs in one cell will be rapidly transmitted to its neighboring cell. So once we get that pacemaker cell depolarized, it sends its signal to the contractile cell. The contractile cells then create their change in membrane potential with their action potential, and that change in membrane potential is transmitted to neighboring cells through gap junctions, and that again causes all of these individual cardiac myocytes to function in a synchronized fashion, or to function as a syncytium of tissue. Now, the way that we can assess the electrical activity of the heart is through what's called an electrocardiogram, and you'll see that abbreviated EKG or ECG. I've drawn on the left here just a very simplified depiction of where our autorhythmic cells are located. So they are located in clusters. One of these important areas is called the sinoatrial node, or typically referred to as the SA node. So this is located up in the right atria, and this is the collection of pacemaker cells that has the highest rate of depolarization. So as long as this is functioning properly, the SA node is going to set the electrical rhythm for the entire heart. So what we'll see happening is the SA node depolarizes, and it's then going to send its signal through those gap junctions, as well as some other connections which we'll not name, but that initial signal, that initial depolarization, is spread throughout the atrial muscle, and it causes the entire atria to depolarize. Well, that depolarization of that atrial muscle, that electrical activity is then transmitted through all of the tissues to the skin, where we can record a change in electrical activity. So what we'll see is on an EKG, we'll see this initial little blip, and this is called the P wave. Now, after the atria depolarizes, that electrical signal is then all going to basically coalesce down at a structure called the AV node. So in a healthy heart, normal anatomic heart, the only electrical connection between the atria and the ventricle is going to pass through the AV node. And the AV node has this ability to basically cause a pause, to cause a slight delay in conduction of electrical activity. And what that allows is it allows the atria muscle to contract in order to push blood through to the ventricles. So we have this initial pause at the AV node, and then the AV node depolarizes, and it sends its signal through a connection of pacemaker tissue. I don't have this labeled here, but it's initially through what's called the bundle of His, the right and left bundle branches, and then it curves up around the edge of the cardiac muscle and then divides into some smaller fibers called Purkinje fibers. And what that does, though, is it allows that electrical signal to be sent throughout the ventricle, and it causes the entire ventricular muscle to depolarize. Now, the ventricular muscle is much larger than the atrial muscle. So there's lots of depolarization going on here, and so we should expect to see a much larger change on the EKG. And indeed we do. And the depolarization of the ventricle is represented on the EKG by what we call the QRS complex. So this is the P wave. This would be QRS complex. Now the ventricular muscle, as we mentioned, is quite large. So when the ventricular muscle repolarizes, that also is quite a shift in electrical signal. And so that repolarization of the ventricle is also something we can measure with our EKG, and that results in what we call the T wave. So these are the three fundamental waves that we'll see on an EKG: P, QRS, and T wave. Now, if you have been in a hospital, you've probably seen this when you hear somebody who's had an EKG done. And this is what we call a 12-lead EKG. So when you take all the different places where the electrical signal is being monitored, so if you see a patient getting an EKG, you'll see multiple little tabs on their chest. What's happening is those are all basically allowing the heart to be evaluated from different angles. And with each of those different perspectives, it's recorded in a different lead. So this is lead 1, this is called AVR, V1, V4, and you can see the different leads that are measured. So there's 4 different perspectives, 3 lines, so this is why this is called a 12-lead EKG. So there's lots of information that an experienced clinician can garner from this electrical activity. Okay? What we're going to focus on in this class, though, is just focusing on the basic lead 1, which is what we call a rhythm strip, which is our very standard P, QRS, and T wave. So realize that as an EKG is performed, think of this graph paper as basically moving through a machine as each of these waves are being recorded. So this really does depict time passing. And this is, again, our standard EKG. So what we see is we're going to see a P wave occurring before each QRS complex. So you've likely heard the term normal sinus rhythm, and that's what this depicts. Normal sinus rhythm is when the ventricular depolarization is caused by depolarization of the SA node. So every QRS complex is preceded by a P wave. What you'll also notice is that the spacing between these QRS complexes is fairly consistent. So this would be a regular heart rate if we were to palpate a patient's pulse. Now compare this to the EKG shown in the middle, in this picture here. So at first glance, you should quickly notice that the space between the QRS complex varies. So it's irregular. And if you pay more close attention to the EKG, you'll notice that there seems to be an absence of our typical P waves. Okay. So this is normal sinus rhythm because the rhythm is driven by depolarization of the SA node. Here we do not have any P waves. This is called atrial fibrillation. Okay, so that means the SA node is not firing and that atrial muscle is not contracting in any rhythmical form. So this would create an irregular heart rate, something that we could palpate if we're checking a patient's pulse. I show this just because this is the most significant abnormal EKG finding, and this is called ventricular fibrillation. So here you'll notice that there's really no recognizable electrical activity of the heart. Everything just seems to be going haywire, and that's what fibrillation is. So in this case, the ventricular muscle is not contracting, so it's basically just sitting there and jiggling like a little bag of worms. So no blood is being ejected from the heart, and so this patient would have no blood pressure. So this term fibrillation then should make you think of a term called defibrillation. So defibrillation is what we do if a patient has this particular rhythm. So this is why we'll see the automatic defibrillators located in many public buildings now across the U.S., because we've recognized the fact that if a patient is in ventricular fibrillation, the most important thing we can do for that patient is to try and get their heart rate beating back normally. And the way we do that is by defibrillating the heart, which is basically giving the heart a shock of energy, basically trying to reset our pacemaker cells and getting a normal rhythm back. thereby producing pumping of blood and returning our blood pressure.